All right, so staying with track one, again, there's two other tracks that are going to kick off here. If you go to, if you want to pop up that website, if you go to ahc2021.com, you can navigate between the different tracks. But if you want to stay with track one, you're in the right place. So we're going to kick off a presentation about coordinating donations during COVID-19. The speakers are Nicolette Louisant, Executive Director of Healthcare Ready, and Sarah Baker, Programs Dealer, Healthcare Ready. Nicolette and Sarah, the floor is yours.
Thank you, and thank you for having us. I first want to correct that and say that Sarah is in fact the Programs Director for Healthcare Ready.
Not sure if that's a promotion or not, but I'll take it.
So I'm just going to awkwardly share my screen for 1 second and pull up some slides, but we are very glad to be with you both, be with you all today. Tony, thank you for the introduction. Laura, Tom, thank you for your hard work coordinating this. We are going to be talking about one small piece of our work over the last year, focusing on donations. We know that there is also a session going on right now on the PPE exchange that was set up by All Hazards Consortium and some other work that will undoubtedly connect to this. And I think the presentation that we were able to hear the last few minutes of the fantastic presentation that was before us, and what we really began to glean from that is a recognition that in addition to all the things that we're talking about, everyone was really dealing with some version of the same problem at the same time. And I think that's important to note. So for those who are not familiar with us, we'll just begin with a quick intro to who we are and what we do, talk a little bit about the various parts of the COVID response that we dug into, and then hone in on, we were asked to give one real resilience case scenario. And so we're going to focus on what we did on donations. So Healthcare Ready is an organization that's actually been around informally for about 15 years, formally for about 14 years. We were founded shortly after Hurricane Katrina. Much like many of the organizations that were founded around that time, the recognition was that there needed to be better coordination. And for us, that mandate was across the healthcare sector, recognizing that across the healthcare supply chain, there needed to be a single point that would allow for coordination across the supply chain, but also with the members of the supply chain, with our partners at the government level, whether that be at the federal, state, or local levels. And so that's why we exist, to serve as what some people like to call a belly button across those partnerships, allowing for us to focus on really all hazard preparedness and response, but really focusing on the healthcare preparedness and response side of this. We are members of the Healthcare and Public Health Sector Coordinating Council. And we also have done quite a bit of work making sure that that coordination body is able to deal with multiple parts of the healthcare system. But we are also an ISAC, and as an ISAC, focusing on information sharing and analysis, especially when it comes to, for us, the physical threats and the supply chain security threats, a lot of things to consider. We are one of two health ISACs, the Health ISAC, and I believe Denise did a presentation earlier. It is our sister organization focusing on cyber threats. We focus mainly on physical threats and making sure that we are doing the information sharing and analysis with all of our partners on threats that can pose a risk to healthcare and public health. So part of what we try to make sure of is that we are thinking about the difference between existing infrastructure and disaster infrastructure. And this is especially important when we're thinking about donations, because oftentimes during a disaster, there is a tendency to focus on creating things that can deal with an immediate solution. And the reality is, if we're not intentional about really understanding what infrastructure already exists, we can create duplicative resources and then still leave remaining gaps. And for us, it's very important to make sure that as we're thinking about fulfilling our mission, which ultimately is to serve patients who have been impacted by a disaster, that we are doing the work to understand what infrastructure already exists in the system, what healthcare systems are around hospitals and clinics, what ancillary care resources exist for people who are not in healthcare. That is everything from a pharmacy to a dialysis center, to an ambulatory surgical site. Those parts of healthcare that are not connected to necessarily a big hospital, but oftentimes are in communities and may be closer to vulnerable communities than a hospital may be. And then some of our newer partners in the disaster response space, like urgent care clinics, who have realized that, especially over the last year, they have a very big role to play in helping us to respond. And so what we try to do is make sure that we understand the capacity, the needs of that existing infrastructure, and then with our partners layer in disaster infrastructure that can supplement the existing infrastructure that will be there long after the mobile clinics or the DMAT teams or the emergency shelter solutions have gone away. With that, I'll jump in a little bit on the COVID response and then turn it to Sarah to do a deeper dive on some of the things that we've done over the last 14 months. It has been quite a year and change for us. We realized that we activated while COVID or SARS-CoV-2 was actually already in Wuhan, China. So we have been activated for well over a year for this particular event. For us, we've seen a range of different types of requests for information or assistance. And this we like to show this because this summary gives a bit of a sense of the breadth of the types of requests that we receive and the types of things that we find that we need to cover. And so a lot of focus, of course, in supply chain status, understanding what it looks like for both the pharmaceutical and the med-surg sides of the supply chain to be able to surge and adjust, being able to do the coordination required to make sure that the types of medicines, for example, that were being used to treat COVID patients would be available at the levels that would be needed based on the rate of hospitalization and the rate of cases that we were seeing at early stages all the way through present. Making sure that we're doing the work to facilitate the process of moving therapies. So we often talk about vaccines, and I'm sure that'll come up, but thinking about the therapeutics that are available that have a role to play as we are dealing with extremely high hospitalization rates and figuring out how we can get those therapeutics moved through the supply chain to be at the facilities where those patients need them. Making sure that as we're dealing with the commercial supply chain, that we're also doing the work of understanding the community organizations, local government organizations, and healthcare organizations that may not be able to afford the PPE that would be available through the commercial supply chain. And so working through with partnerships, a number of strategies to facilitate donations for them. Making sure that we had personal protective equipment that was necessary for medical professionals available for them, and hygiene tools that would be necessary for communities available for them. There's a difference between an N95 mask, for example, going to a community hospital versus a cloth mask going to a local government entity so that they could distribute them widely across the community. Doing a lot of strategic work with a number of community partners, a lot of convenings to educate, provide a lot of technical information, specific information for certain communities, doing a lot of work in communities of color, trying to support the faith-based community as they've been thinking through not just how to survive the pandemic, but also where their support could best be funneled, and then dealing with patient requests as we get them on our hotline. So just a quick snapshot, and I always like to preface this by saying, by the time we show this slide, all of the numbers are completely out of date. But we have been activated for now just over a year. For the first time ever, we've activated RX Open, which is our national pharmacy status reporting tool that shows the status of pharmacies and now dialysis centers. It is activated for the first time for the entire nation and US territories. That was a big decision that we made, recognizing that as people, especially at the point where we were preparing for lockdowns and closures, people really needed to know where they could go to get their medicines or where they could go to seek treatment. In partnership with the Kidney Community Emergency Response Network, we were able to get dialysis status as well, in partnership with CASER and CMS, and through our partners in the pharmacy space, we've been able to maintain that tool, which is now over 10 years old. We received more than 1,000 requests for assistance to be able to assist everything from companies who are having logistical challenges or having challenges being able to understand how to apply certain guidance, all the way to patients who are facing medical emergencies and looking for assistance. That right side of the slide just describes some of the donation coordination work that we've done. And I know we're going to dig into that in greater detail in the next section. So I will just skip over that and move to turning to Sarah on public-private coordination.
Sounds good. Thanks, Nicolette. Can everyone hear me okay? Great. So if you don't mind advancing the next slide, like Nicolette said, going to be talking through, kind of our role in helping coordinate between the private and public sectors. And one piece I wanted to mention, kind of undergirding throughout these conversations and this particular case study is, we're framing this as the COVID-19 response, but a lot of this work happened because there were requests related to what does it look like to respond to a hurricane during COVID? What does it look like to respond to a wildfire during COVID? So a lot of this work was, anchored in COVID, but as we all know, everyone's responding to multiple events at once. And what does it look like to answer questions about how do disaster response and relief during COVID? How do we, prioritize donations? How do we make the right decisions when is it needed for hurricane response or COVID? And what does it look like to balance those? So, I think a lot of us were, put through different decision-making exercises than we have been before and have some lessons learned from that, and happy to touch on those. So as Nicolette mentioned, at the top of the call, our role kind of between sectors and as one of the ISACs for the healthcare and public health sector means we necessarily do a lot of that information sharing. And so, we sit and serve as a liaison between sectors, and, there's a protected space for private sector to share information, private to private sector. I think there's also a way that we're able to take that information and kind of help communicate to government, in a summarized way, in a high level way when needed, what the concerns are of the private sector and how we might be able to, improve coordination there. So as Nicolette mentioned, we work closely and are members of the Healthcare and Public Health Sector Coordinating Council. So that private sector body representing, all the different spaces of healthcare, just how complex the sector is. And, we've been providing supply chain updates on those calls, but also taking information from them, what the concerns are on the pharmaceutical supply chain, the med surg supply chain. What are some of the questions that are coming up as we have, vaccine distribution? So really wanted to, underscore the value of the healthcare and public health sector, the coordinating council there, and how much it, it really grew and became a critical asset for coordination. You can go to the next slide. Again, kind of all terms that folks have been probably hearing all day, and as well as, for the past year, what that cross-sector coordination looked like. We talked about the role of the sector coordinating council and how that body can share information. We also, as an organization, did a lot of outreach to individual states. So making sure that states are aware of the coordination assistance we can provide as a nonprofit, able to really support members in connecting emergency management with public health when they need to, but also more importantly, connecting those community-based organizations into emergency management, maybe for the first time, or into public health for the first time. So really helping to forge those partnerships when they weren't there, or supporting them when they were there and maybe really, just did need some extra support during COVID. And we'll talk about this in depth in a few minutes, but working with state and community organizations to coordinate donations and key supplies. So the donations that we coordinated ranged all the way from hand sanitizer, hygiene tools, all the way to pharmaceuticals that maybe needed to go to a community health clinic or to a pharmacy. So it was a whole range, and I know we've had some slides that touch on those, but really wanted to emphasize just how much cross-sector coordination goes on, especially in the healthcare and public health sector that's uniquely dependent on other sectors, on communication sector, on the water sector, on electricity. So we go to the next slide. This is our high-level summary of kind of the donation coordination, and I'll touch on a few of the examples here. But at first wanted to emphasize, kind of our role and how we worked with federal partners in coordinating these donations, especially during COVID, especially the height of the pandemic. We know FEMA played an absolutely crucial role in helping folks, in helping receive how the private sector wanted to help and directing them where they can plug in and how to do that. So we worked very closely with FEMA's donation desk in routing those health and medical donations. So they often got, offers of assistance or offers of support that, they maybe weren't quite sure what to do with it, or it wasn't an appropriate fit for FEMA to take on, and it maybe wasn't appropriate for HHS to take on. An example I'll provide here is there was physicians in Massachusetts, I believe, who were repurposing scuba masks somehow to be a mask that they wanted healthcare workers to receive. FEMA wasn't able to receive those, weren't sure, they saw that there was good intent there. Are there partners that could use it? So they reached out to us asking, are there maybe community-based partners or others who could take, that kind of resource that wasn't medical grade? Is there a way that we could, share that resource? We know that everyone rolled up their sleeves and got into the COVID response in different ways. So we were helping coordinate and plug in those resources. So I'll touch on a couple of the examples here. First, on our partnership with INEOS. So INEOS is a large chemical composite manufacturer, and they were absolutely incredible in repurposing a number of their plants dedicated solely to manufacturing hand sanitizer. So it's thousands and thousands of hand sanitizer that they had not manufactured before. They wanted to plug in and get it directly to hospitals and other healthcare facilities that needed it, but didn't quite know how to do that, didn't know where to start. So we're able to work with them, turn around, make connections between hospital associations at the state level, as well as primary care associations later on to get that hand sanitizer first to hospitals that needed it, then to primary care associations, so clinics, pharmacies, other non-hospital facilities that needed it. Did a kind of a similar exercise with Procter & Gamble. They also, really came out in force, turning up their manufacturing of hand sanitizer, but also masks that they wanted to donate. And they specifically wanted to donate them to communities of color and had a partnership with BET, actually on a few select cities that they wanted to get these donations to. So we were able to work with state chapters of the NAACP and make those connections so that, offers that Procter & Gamble had got to the communities where the donor wanted it to go, but also where it was needed. So really, again, kind of playing that connector role, making that handshake and those handoffs. We also, last one I wanted to touch on was a partnership with Business Roundtable and Project Hope. So Business Roundtable, another fantastic partner, pulled their members and got a large financial commitment to purchasing PPE that would then be available for donation. So worked with So we, in partnership with Project Hope, helped determine criteria and a process for getting that PPE to states and hotspots that needed it most. So another example where the private sector brought their resources and their commitment to bear, but then needed that hand or needed support in figuring out where it was the most needed and how to get it there. So we're really proud to work with Project Hope on that effort.
And Sarah, if I could just add one thing that was really important to us about the sanitizer and the PPE donations was as we were working through how best to get the sanitizer donated, they came in different formulations and they also were in different types of bottles. And so one of the things that became really easy with the INEOS donation, for example, was to get those gallon bottles to individual healthcare facilities. We could make sure that nursing homes, for example, long-term care centers could get a single delivery because it was ready to use. But when it came to the Procter & Gamble donation, because they were donating drums, we also had to have a process in place for how those drums would then be broken down, which added an extra step, but it also meant that the city could determine how best to use it because it was in this large format. And so in some cities like Baltimore, we were able to work with actually one of their state legislators, their Office of Resilience, and a local I think it's a beer.
I think it was a meadery.
A
So it's like,
meadery, yes.
right, not a brewery, but a meadery.
Yes, they made mead, and which apparently is like older than beer. And they actually were able to sanitize their lines and break that down into small bottles that would then be distributed for free across the community rather than trying to get them into healthcare facilities. And so that, that extra layer of coordination was required to make sure that we could create a process that allowed for these things to be used well. Also remembering that sanitizer is flammable. So for example, in the city of Chicago, when it was moved for donation there, we actually had to partner with the local fire station so that they could hold on to it before it would then be broken down. So a lot of those extra steps are the pieces that people often don't see, but those are the partners along the way that make it possible for us to have such large volumes of a donation actually customized and then move down to people who can actually use them in whatever format we can provide.
That's right. Excellent point. And especially with the gallons or with the drums of sanitizer, it's considered hazmat or hazardous material. So it's not as easy to coordinate those donations of, a pallet that has gallons of hand sanitizer versus an enormous 55-gallon drum of hand sanitizer. What does that look like? And learned a lot more about the different formulations and packaging of hand sanitizer than I thought I would this year. And so here, we've spoken to, some of these themes before, but I think an important role that we play is right-sizing donations to the recipient. So helped coordinate everything from, those efforts with INEOS that had, hundreds of thousands of gallons of donated hand sanitizer. What does a phased approach look like for that? Whereas, got offers of, hey, I have 150 masks. How can I get those to a hospital or to a school? Like, I just want to help. And so I think that's another place where our organization, especially by working with federal partners and state partners, can help right size those. So, for PPE, for example, there was, once we got offers of medical grade PPE, helping make sure that those went to hospitals, that those went to clinics, that it went truly to the healthcare workers that needed. Comparatively, or kind of on the flip side, doing some education and some partnerships on hygiene tools, cloth masks. I think everyone probably remembers, about 10 months ago, 11 months ago at this time, learning the differences between N95s, KN95s, cloth masks, and who should be receiving what. And there was a lot of information at the start of last year that, hey, leave the N95s for health and medical workers, making sure that those don't get bought up, snapped up to, again, well-intentioned people who maybe don't need it. So kind of did a lot of right sizing of donations there, as well as right sizing the recipients. So kind of the other side of the slide here, like we've talked about, we played a big role in, first at the height of the pandemic, making sure healthcare organizations, healthcare facilities, hospitals, but also, community access hospitals. So those are those hospitals that are in rural areas or serving medically underserved areas, making sure they were top of our list for, offering donations, along with local public health departments. To this day, many of them are understaffed and, completely overwhelmed. And so helping to make, offer those donations first to those public health departments that needed them. Spoke to some of these earlier, but, working closely with community partners and advocacy organizations who maybe hadn't been involved in emergency management or public health in the same way before. So grassroots organizations that found themselves, staffing food banks or supporting with health ministries, what it looked like to get them PPE, to get them, the resources they needed to in turn support their community. So kind of as the arc of the pandemic, continues, making sure the healthcare workers and healthcare facilities had their support and what they needed, but increasingly, equipping what I call healthcare adjacent facilities and partners to have what they need, kind of all that supporting infrastructure that we see in food banks, food distribution, caretakers, both formal and informal, making sure that they have what they need. So really working across the spectrum there to make sure that donations were getting where they were needed most. which is easier said than done. I know a lot of donors always want to make sure that, understandably, that it gets, quote, where it's needed most. And should have mentioned this earlier, but kind of in identifying where those hot spots are, or what states, quote, needed it the most, worked closely with FEMA and other partners on receiving their hotspot analysis. So, where were they prioritizing donations, and marrying that up with, our knowledge of healthcare infrastructure in that state or in that region, so that, yes, there's a time when almost all of the country was a hotspot. So how do you prioritize it when everyone needs something? And so we're able to work with Project Hope, with FEMA, with partners to kind of combine those different data sets. So here we've talked about these, hand sanitizer, working with chemical manufacturing companies to get, donated sanitizer, not just to hospitals, but to long-term care, nursing homes, community hospitals, pharmacies, community health clinics as they need it. Surgical gowns, gloves, and masks, kind of that both medical grade PPE and non-medical grade PPE. So, when you need a gown versus an isolation gown, are these surgery grade? Are they not? So working with partners to route those donations, again, where they were needed, whether it was a local health department that maybe just needed gowns for food distribution versus a hospital that needed, surgery grade or medical grade gowns to continue operations. And as Nicola was mentioning earlier, for all these efforts, we really focused on those high-risk communities and facilities and partners who maybe didn't have the purchasing power of a large health system or a large hospital. So they weren't able to plug into the commercial supply chain as they maybe normally would have or would have wanted to. And cloth masks, spoke about these earlier as well, kind of making sure that those hygiene tools got out where they were needed. Exactly.
I think one of the things about the purchasing power is we have to remember that with COVID, it wasn't just that healthcare facilities were seeing a surge. It was also that a lot of healthcare facilities that would not normally be treating a certain type of patient were beginning to see those patients in higher volumes as well. And so when you're thinking about what a community hospital is able to accommodate in terms of ICU capacity or critical care capacity versus a large hospital system, they're going to naturally have different capacities. But during COVID, when you're thinking about places like New York City, everything is overrun. And so that means that the patients that are having medical crisis that would not normally maybe go to a community hospital, they may go to an emergency department for a large hospital, maybe at that community hospital. A clinic may also be overrun because now all the people with chronic care needs that are not going to their normal care or delaying care and now getting to a point of a medical crisis are going to their clinic. And so there's this cascading effect that happens in healthcare when you have hospitals, specifically ICUs, that are past surge and are dealing with having no further capacity. It creates this cascading effect. And because of that, it becomes really difficult to say what facilities might need, the types of patients that they're going to be dealing with at that time. And that data that we got from FEMA about the rate of increase across counties and what we were thinking about in terms of who should be a priority and why is really critical in understanding who needs what when, because that's another part of right sizing. There are facilities that might need things on the med side or the PPE side that would be significantly higher or just different than what they would need previously, but it's because the patient population and the volume of patients that they're dealing with are both changing at the same time.
That's an excellent segue into another kind of point we wanted to make. As the arc of the pandemic continues, as this donation coordination kind of rolled on, FEMA played an important role from the beginning. So did state emergency management agencies. So a lot of times, they were the central place to receive donations, then they pushed them out. As the pandemic, for lack of a better term, stabilized a bit, especially over the summer, state emergency management agencies and state agencies started to back out of donation coordination a little bit. They weren't playing as much of a role. They weren't needed in that same way. But we saw especially those community-based organizations, those non-hospital facilities, kind of what we call ancillary care, still had an enormous need for donations. And so, organizations like ours, Project Hope, other coordinating bodies, played an important role there in continuing that momentum so that donations were still getting where they were needed. And so here's kind of, a graphic depicting what we were talking about, how we work, how we're able to get that insight, what role we play, insights from, government and, supply and donation teams combined with private sector resources, knowing what we know from community partners on the ground and community-based organizations, kind of take that information in and help route it to ancillary care and one of my favorite terms from the last year, healthcare adjacent facilities.
Sarah, while I'm changing slides, would you mind providing a brief description of the work with Fitbit on ventilators?
Sure. So, I think everyone has probably seen stories or, recall stories of, companies that were changing their business lines, whether it was to, make masks or make hand sanitizer like we talked about. A really, cool offer inquiry we got was from Fitbit, who had also repurposed some of their production lines to make a low cost, kind of no bells and whistles ventilator, specifically for community access hospitals or hospitals serving these rural areas, because they know that, combined one, they didn't have the purchasing power for ventilators, especially when we were seeing those, crazy prices for them, but also, they maybe didn't need 6 ICU ventilators, they just needed 1 or 2, or it was kind of peace of mind to have 1 more. So it was a really neat partnership with Fitbit to help make those connections that, Fitbit created a low cost one, eventually we're able to donate them as well. So, a lot of great stories of private sector partners stepping up and plugging in where they thought they could or learned how they could and change their production lines accordingly.
Thank you. So as we think about where we are, this is by far the longest activation we've had. We are still pressing forward, but as Sarah said, some pieces have stabilized in a bit, not necessarily because the pandemic itself has stabilized or the case rate has stabilized at all. Actually, it's more so that the processes that support our ability to coordinate, our ability to understand what's happening, get situational awareness from various parts, distill that down, determine how we're going to work together, and then move to action have become clarified over the last few months. And in some ways, that in itself is a bit unsettling because there are some pieces that we've kind of normalized while the situation itself is still very abnormal. But we are continuing to monitor the situation as well as really tracking things like the new variants that are coming in, the progression of the different medical countermeasures, understanding what that's going to mean for the supply chain, for medical demand, for surge on hospitals and other healthcare facilities. We have a task force of our private sector partners that we continue to convene in groups working on specific subject areas so that they are able to share their insights with one another, work together on cross-cutting issues, but also work with the federal government as partners. We are continuing to serve as a partner to the best of our ability to our federal partners, as some pieces have transitioned from FEMA to HHS, some pieces back to FEMA, some parts back to HHS. And so supporting our partners in both of those agencies as things shift. We're also making sure that we are partnering with our stakeholders that are at the local level. We are working really hard to make sure that the ways in which we have to work together to get information, to glean insights, to determine where the greatest needs are not burdensome. As everyone understands, everyone is stretched right now. So it's very difficult to ask for anything that's in addition to that. So working really hard to make sure that we are very mindful of that. Also, it is January, but it's not too soon to be thinking about the upcoming wildfire and hurricane seasons. We did have an extremely active wildfire season last year, extremely active hurricane season last year as well. And it's important to note, as Sarah pointed out earlier, there are still communities across the country that are still in some state of recovery from those natural disasters while also contending with COVID. But as we saw last year, with the amount of activity that we had, it's reasonable to be preparing at this point, understanding that it is quite possible that we could see equally active seasons, natural disaster seasons this year. And so as we are navigating all of the pieces of the pandemic, also being mindful that with response capacity being diminished, with fatigue being what it is, the ongoing needs related to the COVID-19 pandemic, we do have to prepare for those two seasons with a lot more intention and thinking about how we actually are prepared to allocate resources towards addressing the needs that may emerge. Also beginning to, there's a range of after action and mid action and in progress assessments that are going on. The private sector has taken on a number. Some of our government partners and community partners have taken on others. So continuing to support those, provide insights, and also trying to get as much information as we can from those so that if there are immediate changes that we can make to our response posture, any of the activities that we are taking on, we want to make sure that we are doing that. And then at the same time, a lot of work on the vaccination planning and really, as many people continue to say, it's not just about producing vaccines, it's about vaccines in arms. So thinking about strategies in partnership with our government partners to actually understand how to do that better, as well as dealing with the therapy side of it, because recognizing that it will be a while before we have enough vaccines for the globe, we have to make sure that we can get those therapies to the people that need them when they need them. With that, we've been doing a little bit of evaluation on our side and thinking about what we've learned. I would say there are probably, pages and pages worth of lessons, but these are the themes that we've walked away with as an organization. One is there's tremendous value in cross-sector coordination and cooperation. I feel like we're preaching to the choir in this, so we're not going to belabor this point, but the reason that convenings like this are important and that sector coordinating councils and a lot of the work that many of us continue to do between disasters is so important is because it allows for that cross-sector relationship building, that ability to understand how we work together with those dependencies. And it enables us to have a better understanding of where our dependencies may be and how we can make sure that we are doing our part to support our partners. So when a system is completely down, healthcare is completely strained, or healthcare is in a position where we need relying on our IT and comms partners to be able to get us to a solution that allows for us to continue to deliver healthcare effectively, we have to be able to rely on that sector. And so continuing to see that a lot of the work that we've been laying the groundwork for across, groups like this and others really came to bear. We saw the fruits of a lot of that labor in the last year. Continuing to be concerned about the overlaps of ongoing crises. It is getting progressively more difficult to deal with other events as they emerge in the wake of COVID-19. A lot of our emergency management partners at the state and local levels, they are exhausted. They do not have enough help. They need more manpower, and things keep happening. So really thinking about what this means for us collectively as we have to respond in the future. Equity. And I won't spend too much time here, but I think it's important that we really think about the way that we are addressing equity in the field, making sure that we are understanding how different communities are being impacted by different hazards, and understanding that not every community will be impacted equally. So how we provide support and how we understand our role in alleviating suffering is very important, so that we are not only not causing it, but that we are actually doing work to make sure that we are not blind to the fact that there are communities that may be seeing disparate harm. PPE does remain important. And donations, especially for those communities that were impacted by natural hazards, are recovering from a natural disaster, but also that may not necessarily for their community organizations have the ability to purchase large volumes of product are incredibly important. We're starting to see a lot of concerns, including from one of the CDC morbidity and mortality weekly reports, concerns about what's happening to people with chronic conditions. We know that in this nation, for example, you can pretty much predict the number of heart attacks, the number of strokes that we're going to have in a month. And that has not changed. But what we're seeing is that fewer people are going to the hospital with that. And so understanding what that means for other parts of the healthcare community to be prepared to identify people with medical crisis and support them is going to require supplies. And those parts of the healthcare community, again, may not have the resources to just procure those and may benefit most from a donation. So for us, it's a lot of drawing the straight line between where's the patient need and how does the system adjust itself to being able to support that patient. So with that, we want to thank you for your attention, and we are happy to take any questions.
Fantastic. We'll take a look here. There's no questions coming in yet, but I will add that this is something that I think is great that you've presented on. I know that in many deployments, individuals had to learn not to turn away donations, not to turn away volunteers. That's why FEMA has a course on it. I know when I was in the Virgin Islands, donations were pouring in, and they had to pull a team together to take advantage of that and coordinate it. And I know it's a huge, huge effort. Even during Hurricane Sandy in the EOC, I know that we had individuals that my own company, and I know others worked with, to help get donations out to where it was needed most. And so it was just a great operation to see. So I want to thank both of you for speaking on this topic. I do not see any questions. So again, thank you very much. And we apologize for the swap in the titles. We won't do that next year.
No problem. Thank you so much for having us.
Thank you.
Wonderful.
Great
Thank
session.
you.
Thank you.
Bye.
All right, Tony. So we're going to take a break and come back at 4:50 for a session with Michael Overton. This is on the 511 initiative, so you guys don't want to miss this. But for those of you who are interested in cybersecurity, you may want to check out Track 2, which also starts at 4:50. And that's your competition, Michael, because those are your colleagues teaching that. And Track 3 is doing GIS exercise. So you're really going to dive deep on that one. So please stick around. We'll take a quick break and we'll come back in about 8 minutes. Thank you.